Welcome back to the Pontio Podcast. In today's episode, we have Michael O'Reilly, the neck physio, who'll be joining us, and we'll be talking about all things neck. Well, welcome, Michael.
Thank you. Thanks for having me on this hot Friday. Yeah, no, good, thank you. Keeping cool on this hottest day in June.
Yeah, enjoying the heat wave.
Yeah. Wearing a bit thin now, but it's good.
Yeah, I feel like my face is going to melt off today. So
yeah.
Brilliant, perfect. So in this podcast, in this episode, what we're going to do is just talk about your career and talk about your specializing into the neck and what led you there and further questions to that. So yeah, first of all, how did you get to where you are now?
Well, I qualified in the 1900s in South Africa. So next year will be 30 years that I've been a physio. And yeah, I was fortunate enough to work in a practice with a physio who had actually trained with Jeff Maitland. And now Maitland is a name that only people of my generation will probably remember. The thing about it was that it created a really solid foundation in hands-on assessments and diagnostic skills. And so yeah, I was very fortunate to have that start, and I worked in South Africa in private practice for a couple of years, and then came to the UK in 2000, and then spent 3 years locuming in the NHS, and that was a super useful time because I was just seeing hundreds and hundreds of patients. I remember one locum role that I had, I saw 48 new patients in a week. It was basically 10 new patients a day, except for the Friday. And it was really good just to get that real patient mileage. And it was around that time that I really had a bit of an interest in necks. But I remember seeing a patient when I was working at the Luton and Dunstable. And it was an elderly Irish man who had been referred to the department with it was post-shoulder arthroscopy because he had had a year and a half of not being able to get his hand past his hip on a hand behind back movement. And he had previous physio, and he'd had an MRI, which couldn't really find anything. And then he'd had a shoulder arthroscopy, which also didn't really find anything. And I just had the thought of, well, let's just have he also had a stiff neck. So I just thought, well, let's have a look at his neck and see if there's anything to find there. And so got into his neck, felt that he had a really stiff C5-6. So spent 30 seconds, maybe 2 minutes max, working on the C5-6, loosening up. And for the first time in over a year, he went from hand behind back limited to hip to full range hand behind back. And now I was probably 3 years qualified then, maybe 4. And that just really blew me away as to the impact that the neck and neurodynamics can have. And so that I suppose is one of the key moments where I just thought, wow, the neck is amazing. And the integration of the whole upper quadrant is such a beautiful thing, and there's so much to learn and understand about it. And yeah, so I worked in the Runnymede for BMI, a hospital group that's now Circle, for a couple of years, and then we started our private practice in 2005. And but already then I was most of my clinical caseload was then neck, upper quadrant, headache related patients, and then pretty much for the last now 20 years, that's almost exclusively what I've been seeing is neck pain, chronic upper quadrant dysfunction, headaches, etc. So yeah, that's something I'm always been looking to find ways of treating more effectively, and most importantly, trying to help patients to help themselves better. Because what I saw in being around, having the practice where we've had it for as long as we have, is that patients would initially present, say, with neck pain, and then 18 months, 2 years down the line, they may present with a shoulder impingement or a headache or some other thing. And so they were experiencing a range of conditions, all which could be traced back to upper quadrant function or dysfunction. And that then, what I've seen over the years, all comes back down to the trunk. And how in this information age, and because what I refer to the prevailing wind of the information age. So we're all being drawn into our screens, pushed into our keyboards by gravity and by our focus day after day. And what that's then doing is creating the situation where we get this creeping imbalance through our trunk and forcing the neck into compensatory hyperextension, imbalancing the whole shoulder girdle. And so we get this whole range of different presenting conditions that come about as a result of the first domino or the fundamental problem of this information age driven, creeping, insidious trunk, ever present trunk imbalance. And so yeah, I've said about trying to find ways of more effectively addressing that first domino, and then equipping and empowering patients with the tools and understanding to be able to reset themselves, so they're not just going around that circle of one presentation, then another 6 months or a year for another presentation, etc.
Yeah, definitely creating that awareness as well of what might be causing the difficulties. So I found that really interesting, going back to your initial introduction to working with the neck. The work that you did to get that gentleman to go from hand behind back to hip to full range, was that more hands-on or exercise-based? What was your treatment in the first instance?
So in the first instance, it was all just hands-on. Yeah. So again, because I'd had that really good foundation in developing my hand skills, so that's both from a diagnostic, but then also from a treatment intervention point of view. Because I know there's plenty of people now who will say, mobilizations, joint mobilizations is useless, blah blah blah. I mean, what they're actually saying is they don't know why it works. But for people who trained when I did and people who've invested in those skills, we know that it works. And funny enough, I was talking to another physio who's similarly long in the tooth as I am earlier today, and she was also just saying how often patients are blown away when they've seen other people doing, what has become the modern just bit of advice, bit of exercise, bit of strength, but haven't improved. And then they come to someone who actually has invested in their hand skills, who can identify and correct a problem. What a profound difference that makes in their rehab journey. Mm-hmm. So it's not all just about it's not just about manual therapy, it's not just about exercise. For us to invest in our profession and in the future of our profession, both individually and also the wider profession, we have to be making sure that we are developing a broad range of skills. Yeah. And just because we can't specifically research one tiny aspect of it doesn't mean it doesn't work, and doesn't mean it's not valuable. Yeah. And I'm seeing patients every day who are coming to us to benefit from what we do from a hands-on point of view. So to answer your question, what made that immediate and profound difference for that patient was mobilizing and loosening up his lower cervical spine. So my thinking on it would have been his C5-6, maybe 6-7, long time ago now, I can't really remember, but there would have been a limitation to his neurodynamics around the radial nerve and C5-6, which is then limiting his internal rotation because of where the radial nerve wraps around from outside to in. And just by freeing up those potential restriction, tethering points, whatever you want to call them, that allowed that nerve to glide and therefore allowed that whole quadrant to free in that particular movement.
Yeah. So I find it really interesting when I hear people talk about the hands-on versus exercise or hands-off approach. I'm with you. I believe it's a blend of the two, just like many things in those sort of debates. Do you think within the treating the neck, it's different? You'd say it's more one than the other, obviously a blend of the both. Would you say it's 50-50 for the neck or 70-30? What's your stance on that?
I think it's difficult to put a specific number on it. I think it's all a matter of, in my book, clinical excellence is about being able to use the right tools at the right time and the right way. Yeah. And based on a presentation, it could be that it is a movement control problem, and therefore it is going to be far more exercise based. for another patient, they may be far more of a stiffness issue. So then it's going to be more hands-on. The thing is that there will always be a very important and a fundamental role for exercise, because exercise is a key part of that empowerment. We obviously want to educate patients to help them understand what's driving their problems and what they can do to help themselves, but it's also about equipping them with the tools to be able to make that change. And I think this is the other thing that I've seen over the years, is that if you can be like making that immediate change to a patient, you are then getting their immediate buy-in. And it's that creates that relational equity and that trust that then allows you to deliver your other messages of, okay, this is why I want you to do that, but I've earned the right to tell you that because I've made an immediate change to you. You've come in thinking, gosh, this person knows what they're doing, and I can feel the difference. And now I'm giving them my attention so that I can take what else they have to say from the patient's perspective, that is.
Yeah. Would you it's a common conversation you have with people, and you hear the prevalence of neck pain being a lot higher than elsewhere in the body. Would you say that's because of the information age that you were talking about earlier, or do you think that's more down to difficulty of treating the neck?
I think that there's a couple of things. It's a good question, that. I think that there's been a fundamental change in, obviously, the world we live in now is very different to how it was 30 years ago, 50 years ago, etc. But I think there is a fundamental change in the way that we live and how static our lives have become. Our lives are sedentary, but even for those of us who are active, there are big periods of being static in between. So it's the combination of being sedentary and static. And nobody uses a photocopy anymore. Nobody uses a filing cabinet anymore. We all just are at our machines. And when we're not looking at one screen, be it our laptop screen or our computer screen, we're looking at a phone screen, or we're looking at an e-reader screen. So I think that there is a big environmental, societal, almost evolutionary change to that, societal evolutionary change. And that stasis means that we are losing the battle to gravity, because we are in one position or a very small range of positions for so much time. Gravity wears us down, and we end up giving way to gravity, spending time in too much trunk flexion. So we then end up with stiffening of the mid-thoracic and spine and thoracolumbar junction. We adaptively shorten and tighten and through the anterior myofascial chains, and we effectively then become prisoners in our own body. The problem is that it happens so insidiously that you don't realize you're a prisoner until either your body is shouting at you in the form of pain or other symptoms, or we just wake up one day and think, gosh, I can no longer check my blind spot, or I can no longer reach up into that top shelf. But it's a process that's been happening for months, years, and sometimes decades. Gets us there. But to answer the second part of your question, I think that there's a real lack of education, and there's a lack of training when it comes to managing the neck. I think it's something that is actually is incredibly rewarding, and not only from a professional point of view, but of course from a patient point of view, where we can make a big difference to them in a short space of time. But there's a real fear around treating the neck. And so that's led to everybody backing off of it, and it's led to us doing less and less, and the loser in it all has been the patient, because they are living with increasing neck pain, neck problems, and neck debilitation, etc. So as you say, the figures of neck pain are just dramatically on the rise.
Yeah, definitely. So is there a tool that could help you win that fight against gravity?
Yeah. So the thing, by my clinical reasoning, the first domino in the whole problem is that creeping trunk imbalance. That progressive shortening and tightening of the anterior myofascial chains, pulling us into flexion anteriorly, so an anterior pull posteriorly, we're all getting pushed into flexion by stiffening of the mid-thoracic spine and the thoracolumbar junction. So we've got a push and a pull going in the same direction. So flexing trunk leads to increasing compensatory demand on the neck. So we're spending more and more time in neck extension, leading to compression and all the other issues. So no matter what the presenting symptoms are at the end, so those latter dominoes in that clinical reasoning process, if we don't set about restoring trunk balance, the problem is always going to be reset. So we'll deal with the presenting symptoms and things like that, but before long it's going to come back. So fundamentally, what I find to be the invaluable, not only I, but plenty of other physios and osteos, etc., find to be an invaluable tool in addressing this is the OptiNeck balance wedge, which is a simple tool that is about helping patients to get into the habit of resetting that trunk, the trunk balance and the trunk dynamics by restoring trunk extension, so thoracic extension, and easily opening up the anterior chains.
Yeah, bro. Well, I was very thankful when you sent over the balance wedge to me, and I had an opportunity to try it out myself, and I found it really interesting. First of all, I love the QR code at the bottom, really simple to use, and the optional exercise that you can try out using the wedge.
Yeah.
My first question is it meant to be that uncomfortable?
Well, so in what way did you find it uncomfortable?
Well, alarming. It's quite alarming in the sense of I think I needed it because
Right.
So just I placed it, put it in position, started to lie on it, and I started to do some scapular setting exercises.
Yeah.
And what I found interesting, like I said, it was very uncomfortable, but I probably after about 6 minutes, that discomfort started to fade away.
Yeah.
And I started to kind of feel myself relaxing into the wedge a bit more. It might have been a bit of getting used to it and a bit unnatural, so everybody would tense up. But yeah. So have you found that yourself in terms of that rigidness to begin with?
Yeah. So I would guess that where you probably felt the biggest or the most discomfort would have been kind of mid-thoracic spine,
Exactly.
maybe like centrally down to almost thoracolumbar junction.
Yes.
And you probably would have experienced that as a pressure. And you're probably thinking, gosh, this is so hard. Why is this so hard? What am I doing? Well, what the wedge is actually showing you is how uncompliant or how stiff that part of your spine is. So what it's doing is essentially shining a light, like giving us almost X-ray eyes into where your system can move and where it can't. And the reason why you experience that there is, I'll just get a one I prepared earlier. So if, as we spend our day in flexion, screens pulling us forwards, we get more and more flex through the mid-thoracic spine, right? Now, that should be able to easily straighten up, right? And this is the whole thing. People say, oh, your best posture is your next posture. I think that's, unfortunately, in this modern age, the biggest load of BS that has ever been purported by the physio fraternity, because most people don't have a next posture. We spend all our time in flexion and we stiffen into flexion, and therefore our ability to actively get out of that flexion becomes increasingly limited. So what is then happening? So we're in this position, we're getting stiff over there. Now you come to lie on the wedge, right? The wedge is underneath here. If you've got a compliant mobile spine, you should be able to quite easily take up that full base of support and flatten that thoracic spine off. Yeah.
Yeah.
But even in your young, how many, 20-something years?
27.
27 years, as a young man at the high water mark of your spine's health, you are already, I would dare to say, already quite stiff. Because as you were then lying on the wedge, you would have been point loading virtually through a very narrow area. But now as the minutes go by and as you breathe and your ribs articulate and you free up your costovertebral joints and gravity's pushing down, the ground reaction force is pushing up, we then start freeing up and loosening that thoracic spine.
Mm.
So after that kind of 5 or 10 minutes, it actually now feels a lot easier, because
Yeah.
now you load bearing along a much longer surface and on a more mobile spine. And if we then translate that to being upright, we then back up to there.
Yeah.
Yep.
That
Having
makes a lot of
reduced that extension, reduced the flexion, and therefore then reduced the compensatory extension, hyperextension load on the neck, and bringing the center of mass of the head back over the base of the support of the pelvis.
Yeah, that makes a lot of sense. So
Yeah.
would you say it would help a younger patient then with potentially more mobile spine? Do you think there'd be more the results would be more successful, or it doesn't work like that?
Well, it depends what the underlying issue is. I mean, clearly it
Yeah.
helps 27-year-olds. So it's what we're seeing is that postural imbalance is becoming a bigger and bigger issue for teenagers because they have grown up in the tablet screen world.
Yeah.
So their spines are being formed in an imbalanced environment. So anybody over the age of like 35 or so would have been through our teenage years mostly being far more upright, being far more active, not being digital natives as they're called. So at least people sort of 35 and beyond have had a better chance of starting from a more biomechanically optimized position. But what we're seeing with the teenagers and the early 20-somethings is that because of the amount of time spent in front of screens, their systems are forming in an imbalanced arrangement.
Yeah.
So over time, we all tend to get imbalanced, but if you're starting off okay, you've got a better chance than if you've already formed in a slumped and kyphotic, anteriorly shortened position. So, and I do really, this is one of the things that drives me on, that I'm so passionate about, or why I'm so passionate about getting this message out there, is because this is going to create a huge public health problem in the years and decades to come.
Yeah.
We cannot be so biomechanically imbalanced without there being significant consequences to activity, mobility, morbidity, and if you extrapolate that out into those later, middle to later years, we're going to have populations that are much less active and much more of a burden for themselves and for society than we currently have.
Yeah, I understand.
Yeah.
So if so I've got the wedge now. How would you prescribe me to use that wedge? How often? How many times a day? How many times a week? What type of exercises would you do for just general mobility? So I haven't got any conditions in my spine. For someone like myself, what would you suggest?
So as a general rule of thumb, we'll say that for every hour you spend in front of a screen, you want to be doing 2 minutes on the wedge. So if you've got a 7 or 8 hour working day, then you want to be doing 15 minutes on the wedge at whatever time of the day works for you best. For some people, that's middle of the day. Some people, it's the end of the day. That really doesn't matter. What matters is how regularly you can be resetting. Because this is essentially, it's a tug of war. It's kind of I talk to patients about balancing the scales. Like on the one hand, you've got all the imbalancing, loading, irritating activities or elements of a week. And on the other side of the scale, you've got your corrective ones. And that's a very dynamic process in that some weeks an individual can be doing a 50-hour week. And so that's going to load that down a lot. So then you've got to put other things in. But then you go on holiday for 2 weeks and you're up and about and you're not stuck in front of the screen, then you need to do less. But the important thing is that we give patients a different experience of movement and give them an experience of this is what it's like to be upright. This is what it's like to regain your central long axis. This is what free movement is like. And so you then, once you've given them that experience, they then want that experience. If you give them the experience and a way to regain that experience for themselves and reproduce that experience for themselves, then we go a long way towards creating a habit. And the key thing with all of this is about habit. We need to equip patients with the corrective, restorative habits for whatever their movement is, whatever their movement problem is. We need to be, if we don't change their habits, we don't change their outcome.
Yeah.
So, and that's where one of the real values of the wedge is that it's so easy to use, and the vast majority of patients report feeling profoundly different even after 1 or 2 sessions, and that then facilitates that habit loop and goes a long way towards helping them move better for longer.
Yeah. Okay. Well, I've also found interesting. I was researching the wedge before this call with you today, and for a physio using it for treatment, just they'll just place it what seemed like on the plinth, and they'll just use their treatment that they would have done, but just simply get them on the plinth, and even that would provide the benefits, extra benefits.
For sure. Absolutely. It comes back to, I'll take another long way to answer that question, but I would imagine the other thing that you experienced is if you did the arm opening series, that you may have well experienced or been surprised as to how short and tight your pecs and your anterior chains were. I mean, don't let me put words in your mouth, but I mean, did you experience that as well?
Well, I tried one and I gave up because you're exactly right. It was too much.
That's
Yeah, I do need to stretch more.
Yeah. But the thing is, this is what I've learned over the years, right? Is that we think, oh, that's just because we stiff and we need to stretch more. Actually, that is a fundamental driver of that creeping upper quadrant imbalance. That's going to be driving impingement. It's going to shoulder impingement. It's going to be driving cuff arthropathy. It's going to be doing all sorts of things, and tendinopathies and all sorts of things along the way. So I've somewhat forgotten your question. So ask me again.
Yeah, so it was more about it wasn't so much a question, it was more of an observation in terms of treatment. Yeah, so just using the wedge. Carry on.
Yeah, so that's it. So if, let's say I was treating you, right, and you found that, oh my goodness, I can't get beyond that. First of all, the first question is, why is it that you're really struggling to get beyond that? And I would say the answer is that you spend most of your day forwards over patients, forwards over keyboards, on phones, on tablets. So most of our days, for most of us, are in that closed-in flex position. So we progressively lose the ability to do that. So if we can just get patients doing that on a regular basis, that's going to be beneficial. But so if I were treating you, I'd be then thinking, okay, maybe your primary issue is that you are so short and tight through that anterior chain. So I'd be getting you on the wedge, and I'd be having a deep dive into that pectoral fascia, both the short chains and the long chains, and then using whatever hands-on techniques to release that and open that out. But while I'm doing that, with each of the deep breaths you're taking, we're getting that thoracic extension mobilization and getting that whole long central chain opening up. So it really gives you like another pair of hands. So while you're treating the patient, you're doing one thing, gravity's doing something else for you with the facilitation of the wedge. So
that's a really nice way to put it. Yeah.
So it's kind of like I always think of my treatment room as a workshop. That like I have these systems and these machines that come in that are just not working the way that they should do. And it's a matter of, right, let's get that machine onto the workbench and let's see how we can find what the problem is and how we can make it work better. But part of that, an essential part of that workbench will be saying, well, this is the jig, this is a platform on which we want this system to be able to move around. And that is then what the wedge has become. It's like, right, let's get you on this, let's get you moving around this. It's going to be addressing those two main drivers, and it's going to be making my life a lot easier. But then also, when you as the patient then invest in a wedge and you take it home, you can then be reproducing and replicating is the word I'm looking for, a lot of that movement correction for yourself. So you can be taking steps forwards between sessions rather than stagnating or slipping backwards. So
no, it's really good. So I have to move on because we try and keep these podcasts quite short, but it's really, really interesting work that you've been doing. So we'll provide a link into the caption of this podcast for anyone that wants to have a look at to the balance wedge, and also a link to your socials, obviously, as well, to have a look further as well. Perfect. So we're going to end the podcast with a little quick fun question. What's the word of it? Quick fire question.
Quick fire questions.
There we go. Brill. So First question, nice and easy. Coffee or tea before you start work?
Coffee.
Real. Favorite exercise to prescribe for neck pain?
Wedge time.
If you weren't a physio, what would you do?
Well, I was a racing driver for a while. I wasn't professional, but I'd probably be a professional skier, a ski instructor. That's what I'd be.
One thing physios should stop doing.
Oh gosh, no. How do I boil it down to one? Physios should stop putting their own necks in a noose.
One thing you've learned from developing the balance wedge.
That a change of perspective is powerful. That's what gave me that idea in the first place, and that it's all about habit. Hit the fundamentals, focus on the roots of the problem, create a habit that addresses the roots of the problem, and you can lead to profound change.
Lovely. Perfect. One thing that physios should start doing.
Investing in their hands, because your hands are your eyes, and your hands are the things that will separate you from AI and the robots, and it's the thing that will keep you employed for years and years to come.
I think that's a really lovely way to end this episode. Thank you so much for joining me today, and I wish you all the success with the balance wedge.
Excellent. Thanks very much. Really appreciate your interest.
Perfect. Thank you, Michael. Bye-bye.
Thank you. Bye-bye.